So now we're going to learn about tools for abdominal trauma. After primary survey, we go to adjunct to primary survey. You need to check the glucometer of the patient, and also maybe you want to do a arterial blood gas or venous blood gas. And if the patient complain of chest pain, you can do an echocardiogram (ECG). And if needed, you put a rice tube and also urine catheter, and you ask for x-rays, which is cervical epilateral, chest erect or supine. It depends on the patient whether the patient can stand, or if the patient cannot stand, then the patient have to lie down, and then the view must be supine, and also pelvic epilateral. For adjunct primary survey x-rays, we no more do cervical epilateral unless you are working in a hospital that doesn't have a CT scan available. Then you need to do a cervical epilateral. But if the hospital have a CT scan available, then you no need to do a cervical epilateral x-ray. You just do chest and pelvic x-ray for adjunct to primary survey. And lastly, don't forget to do your FAST, focus assessment sonography for trauma. So next in FAST, focus assessment sonography for trauma, is an ultrasound that you have to examine at 4 regions. If you can see here, A is hepatorenal region, B is splenorenal region, C is pericardial sac or pericardial view, and D is pelvis or pouch of Douglas region. So you do FAST in trauma patient, and especially in patient that you suspect to have intra-abdominal injury, okay, bleeding in the intra-abdomen. So when it's positive, if it is positive, means there is a fluid in the abdomen. Okay, there are few limitations in FAST. Well, first it depends on the operator. If the operator is skillful, then it is easy to see, easy to get the view, and it's also the view is interference with the bowel gas, and also in patient that is obese. And once you see there's something there, you cannot differentiate whether it's a blood or it's a fluid. But if with the history, with the mechanism of injury, then you suspect this patient is having a bleeding, so the chances that what you will see is highly likely is blood. Okay. And then, but in FAST, this you cannot identify if the patient have a retroperitoneal injury. Okay. And at the same time, FAST also cannot differentiate whether it is a solid or hollow organ injury. So basically in FAST is where you want to find whether the patient is having bleeding or not in the abdomen, which is the bleeding can be seen in the hepatorenal fossa or splenorenal fossa, or at the pericardial view, or at the pelvic or pouch of Douglas. First view is the hepatorenal fossa. As you can see, there's a probe there, so the probe marker is towards the patient head, and you put the probe at the anterior axillary line of the patient, and you rotate the probe obliquely and scan from cephalad to caudate to visualize the diaphragm, liver, and kidney. Okay, so as you can see here, there's the liver and the kidney. This is the first picture, okay, and you can see the hepatorenal recess. Okay, this is a normal view. The second picture is the abnormal view, where you can see a fluid in between the liver and the kidney, which is the fluid is in the hepatorenal fossa, or you can call it as Morrison pouch. Okay, Morrison pouch. Okay, um, the fluid is a black hypoechoic or anechoic appearance. Okay, we call it hypo or anechoic appearance. So next is B, the splenorenal fossa view. You put the probe of the ultrasound on your right, which is on the patient's left, and you put the probe marker toward the patient head at the coronal plane at the anterior line of the patient. And here you can find the spleen, the kidney, and the splenorenal recess. For the first picture is a normal view of a patient, and then the second picture where you can find the free fluid, okay, in between the spleen and the kidney. So the free fluid is in the splenorenal fossa. It is a hypoechoic or anechoic strip. Okay, so this free fluid is actually blood if the patient is having trauma and complain of abdominal pain, and you suspect the patient is having blood in the abdomen. So when you do scan at the splenorenal fossa and you find the free fluid here, so this is highly likely there's a blood there, indicate that there's a injury to the organ in the abdomen. So next is C, the pericardial sac or view, where you put the probe marker to the right at the subxiphoid space. Okay, you have to press a little bit, and then you're going to find the fourth chamber of the heart, the right ventricle, left ventricle, right atrium and left atrium, and also you find the pericardium. The pericardium is hypoechoic. Okay, so when you find there's a black view there, it is the effusion or the blood. Okay, it is hypoechoic or anechoic. Okay, so the pericardium is the hypoechoic, the white color, whereas the effusion or the blood is hypoechoic or anechoic. Okay, indicates that there is a bleeding in the pericardium. Last view is D, the pelvis or pouch of Douglas. You put the ultrasound probe above the pubic bone with the marker pointing to the right in the first picture. Then you rotate the probe 90 degrees, so the probe marker will be towards the head. Okay, there you find the bladder. Okay, and in the first picture you can see B is bladder and U is the uterine. Okay, what you need to do is you need to find for an area of hypoechoic, okay, which indicate fluid around the bladder. As you can see in the second picture, there's the bladder and the uterus, and you can find there in between the bladder and the uterus, which is we call as the pouch of Douglas, you can find the free fluid there. Okay, which is hypoechoic or anechoic, which indicates bleeding at the bladder or pelvic area. Okay, after you completed your adjunct to primary survey, you proceed to the secondary survey. In secondary survey, you need to do a full examination from head to toe, and here you need to look for any hidden injury. Okay, After you have completed your secondary survey, you go to your adjunct to secondary survey, which is you will order for any other x-rays that you suspect of any other injury, and also you do a diagnostic peritoneal lavage, which we normally did not do it anymore. And because you already have your FAST, focus assessment of sonography for trauma, and then you ask for your CT scan, okay, because you suspect of abdomen and pelvic injury, so you order CT abdomen plus minus pelvic CT or plus minus thorax CT, because uh, if you do a abdomen CT, usually you have a patient that might have a pelvic injury also, and if the patient have an abdominal injury with a pelvic injury, the patient might have a thorax injury as well. So you do a CT abdomen plus pelvic plus thorax. For blunt trauma patient that is stable, you can still proceed for a CT abdomen, but if the patient is unstable and you have positive finding in your FAST, means you found free fluid in your FAST, free fluid indicates of bleeding, then you should straight away refer to surgical for urgent laparotomy with your FAST evidence, no need CT scan. But in penetrating patient that is stable, you proceed with your FAST, look for any free fluid, and then if the patient is unstable, penetrating, you no need to do for CT scan, you just refer to surgeon straight away for urgent laparotomy. Okay, unstable means the patient is having low blood pressure with a systolic PP of less than 90 and the patient is tachycardic. Okay, means the patient is in shock. Okay, in unstable patient with suspected of intra-abdominal injury, there are a few signs or findings that you can see. First is in your chest x-ray, when you do your adjunct primary survey x-ray, you can find an air under diaphragm, and also if the patient is positive in your FAST, focus assessment sonography for trauma, and also you found in your CT abdomen there's a organ injury, and also if the patient is having peritonitis, complaint of abdominal pain. Okay,